Assalamu alaikum. Today we are going to have a discussion about a very important disorder, that is the central pontine myelinolysis, which is also known as osmotic demyelination syndrome. In our clinical setting, sodium-related disorder is very common to be encountered, and whenever we are doing some rapid correction of hyponatremia, it can lead to this osmotic demyelination syndrome or central pontine myelinolysis. So let's have a discussion about this disease in a deeper aspect. Okay, so central pontine myelinolysis is a serious neurological disorder characterized by demyelination in the central pons, which is particularly related to rapid correction of low sodium level or hyponatremia. It is of a grave neurological significance. What is the most commonest etiology? Whenever we're doing some rapid correction of hyponatremia, it can lead to CPM. Alongside the other factors like malnutrition, hepatic insufficiency, okay, or liver failure, or sometimes alcoholism, that can also lead to this central pontine myelinolysis. Another thing that we notice from the study is that whenever the central pontine myelinolysis occur, the symptoms to be developed within 2 to 6 days. Not immediate symptoms. The symptom can occur from 2 days to 6 days. Okay, after the correction of hyponatremia. Okay, if there is a study which showed that if severe hyponatremia was corrected too quickly, like 23 milliequivalent per liter within 24 hours, the coma, which could be a grave consequence, can occur 2 days later. Okay, and if the serum sodium is quickly lowered to the previous aspect, then slowly corrected, okay, the neurological symptoms can be improved. So we need to remember that. So apart from the rapid correction of hyponatremia, the malnutrition is one of the important risk factor. Hepatic insufficiency or hepatic coma can lead to this CPM alongside the alcoholism. We need to remember this thing. এখন, what is the neurological symptoms of osmotic demyelination syndrome? As I told earlier, the delayed onset of symptoms, particularly 2 to 6 days following rapid correction of hyponatremia, can lead to the symptoms like confusion, ataxia, dysarthria, even the coma. There must be some behavioral changes alongside with that. And the severe complication can lead to something called the locked-in syndrome. What is the locked-in syndrome? It can be associated with quadriplegia. Patient can also have some difficulty in the horizontal gaze. Only the vertical gaze should be correct in this condition. So patient will be complete quadriplegia. There will be no speech. There will be only vertical eye movement. As the vertical eye movement center situated in the midbrain, and most commonly it is involving the pons as well. Alongside, there is some respiratory involvement as well, because of the center is the medulla, and alongside the patient can have some depression as well. Okay, so is there any case study? So as I told earlier, there is the important thing is that the initial condition, if there is rapid correction, okay, there could be some severe neurological impairment like coma, which can occur after 2 to 6 days. Not immediately, but it can occur after 2 to 6 days. If we rapidly intervene at that period of time, his neurological symptom can be resolved. And another important thing is that it can occur in the pons. So whenever the symptoms is in the pons, the patient can have the locked-in syndrome, as there is all important tracts can go through the pons. So there will be entire quadriplegia, there will be entire episodes of patient will not talk to you. There could be involvement of horizontal gaze, as the horizontal gaze center is situated in the pons, but the patient can blink the eye vertically, as the vertical gaze center situated in the midbrain. Okay, is there any extrapontine symptoms? As I told you, there is two types of involvement in myelinolysis. One is the pons involvement. They can cause a central pontine myelinolysis, and there could be extrapontine involvement as well, like the basal ganglia, like the thalamus, like the cerebellum. So sometimes it can have some postural tremor. There could be myoclonic jerks. There could be psychiatric feature. There could be Parkinsonian symptoms as well, due to involvement of basal ganglia and other parts of thalamus. So, is there any role of imaging regarding that? is there any role or MRI is a good tool to detect the CPM or osmotic demyelination syndrome? Answer is yes. MRI is a very good tool for diagnosis. As we can see, there is something called the trident sign. What is the trident sign? It is just like the Hindu gods or something like that. That is the typical manifestation of trident sign. Okay, if there is trident sign in the pons, that can be related to this condition. Okay, so trident sign is a very important sign which could be related for the diagnosis of central pontine myelinolysis, which is just like the 3 edges short. Okay, so important thing we need to remember that trident sign, which is important for this central pontine myelinolysis. As you can see, there is a trident sign. Okay, and there is, if we see the pons, there is 1, 2, and 3. So trident sign is an important thing which we should follow whenever you're suspecting a ODS patient. It is also something like a omega. We also call it omega sign. So trident sign or omega sign is very important for central pontine myelinolysis. Now, is there any more sign? There's another sign very important we should remember, that is called the face of the piglet sign. As you can see, this is a piglet. If you see this image, there is a piglet. It's the eye of the piglet. This is the eye of the piglet, and this is particularly the mouth of the piglet. This is the mouth of the piglet, and this is the snot of the piglet. Okay, so in this condition, this is the fourth ventricle. Fourth ventricle is the mouth of the piglet, and if we see, and what is this thing? This is the snot of the piglet. The pons is resembling just like the snot of the piglet, and this artery, that is very important, the internal carotid artery, just resembling the eye of the piglet. This is the eye of the piglet. This is the snot of the piglet, just like this, and this is the fourth ventricle, mouth of the piglet. So face of the piglet sign is another important sign of central pontine myelinolysis. Okay, so just like the ancient Greek or Hindu spear, the trident and face of the piglet sign is a very important thing for this ODS or central pontine myelinolysis. Is there any important or effective treatment goal regarding that? So among the patient who have the increased risk of osmotic demyelination syndrome, like the rapid correction or alcoholism or alcohol-related disease or malnutrition or advanced disease, or in the patient have severe hyponatremia lasting more than 48 hours. Okay, if it is less than 48 hours, for the diagnosis of hyponatremia, we can correct it rapidly. If it is more than 48 hours or we don't know about the duration, it is recommended that sodium correction should be done from 6 to 8 milliequivalent per liter. If we correct it more than that, it can always lead to ODS. Okay, so important conclusion is the causes of CPM, like the rapid correction of hyponatremia, along with some risk factor like the malnutrition, hepatic insufficiency, or alcoholism. Okay, the neurological sequelae particularly occurs 2 to 6 days after. Okay, it could be due to pons related manifestation. It could be related to extra pontine manifestation like the basal ganglia or the thalamus or cerebellum related problem also. The important treatment strategy is to check when we need to correct the sodium. Okay, the rapid correction or particularly correction in a risk factor that can be lead to these types of symptoms as well. So that's it from the central pontine myelinolysis. Thank you so much. Let me know if you have any query regarding the pathology or features regarding CPM. We're going to have a further discussion about how we manage this condition and what should be the ideal thing to prevent this condition in the medical science. So that's it from the today's lesson. Thank you so much for your patient hearing.